Welcome back, and thank you for joining us. I want to welcome to our program Dr. Bhuvana Sagar, National Medical Director at Cigna Healthcare in Houston, Texas. The issue of patient-centered care is being emphasized across the cancer care continuum, but it remains a work in progress. Dr. Sagar, at what stage does cancer care become patient-centric? When does that become important?
I think that patient-centered care becomes important right at the time of diagnosis, possibly even at the time of suspicion of cancer. It's a very emotional time. I was just talking to a couple of folks yesterday where this is people that have a great understanding of insurance and cancer. The minute that there's a suspicion of cancer, immediately everybody gets into a panic state. So I think patient centricity should begin right there. Physicians should take the time to explain to them what they think is going on. Try to make an educated guess. The time till they get the biopsy results is probably the most critical. Once they get the biopsy and the scans done, trying to sit down and have a clear conversation about what the diagnosis is, what the stage of cancer is, and treatment options. And of course, I think that part is probably much more important. But as we go along through the journey of cancer, early palliative care becomes important. Management of symptoms is key. I think there's been a lot of controversy about palliative care versus hospice care. I don't think those should be confused. Palliative care early on in the journey is critical in transitioning the patient, and they don't have to have terminal cancer, in my opinion.
Wonderful. Bob, as someone who's intimately involved in the development, dissemination of practice guidelines, is there a point in the decision node when patient centricity is turned on like a switch?
No, I think patient centricity should be a constant over all healthcare, not just cancer care, but all healthcare within the United States. Everything that we do should be to try to optimize outcomes for patients. I think one of the things that we have to be cautious of is that patient-centric care doesn't always mean that the patient is happy. There are things that we do that sometimes make patients unhappy but are for their own good. You need to lose weight, you need to stop smoking. No, I can't give you narcotics for that. No, your bronchitis won't be helped by antibiotics. So I think that, but those are things that are good for patients in terms of outcomes, but don't always make patients happy. Hopefully most of the things we do for patients that are patient-centric make them happy, but the well-being of the patient needs to always be at the center of what we do.
Yeah. I'm interested, you say optimize outcomes. What outcomes? And I think that gets to the question of who defines what outcome is important. Is that the physician? Because if we look at any medical journal, whether it be the Wall Street Journal or the New England Journal, the only things we report on are progression-free survival or overall survival. At what point do patients define what an important outcome is? And and are we good as a delivery system, as physicians, about considering patient perspectives on what's important?
No, we're not good enough at that, and we need to be better. That typically today is considered a patient-reported outcome, and what is optimal for them, and so forth. But the challenge is, what are the best outcomes? What is quality? What is value? All of those things are somewhat in the eye of the beholder.
Yeah.
And I think we're in a situation where there are multiple different perspectives, all of which are probably valid, and the truth for the utilitarian system of healthcare in the U.S. is probably somewhere in between all of those different perspectives.
Yeah.
Patient-centered care is such a great term until you're a patient and see what it really is like. And I think the first thing that we need to do in this country is start understanding the consumer and the patient. And we need to start thinking about who's at the center of this equation. Because so much of what we do and how we do it may be called patient-centric, but very few people actually offer patient-centric care. We've been working on this for a long time. The patient-centered medical home. Some places do it well. A lot of places, unfortunately, don't. You have to figure out costs, reimbursements, and people, whatever. It's a topic that's sort of top of mind for me and for many others, because we have to start paying attention to the quality of life, the quality of the experience. We have to start understanding more about it, and we don't do it. Well, you know, this is an industry. When I say industry, it sounds terribly, I don't know, it sounds sterile, doesn't it? But these are people's lives. And we need to figure out how the person who we're treating perceives the care we're offering. And we have to start thinking about what we can do as making that experience better. So I've sat in meetings where we've spent a whole day or 2 days talking about patient-centric care, and everybody brings their own perspective to the table. No, you know, everybody had a different definition of what makes patient-centric care. And it was actually a very interesting discussion, depending on your perspective and where you're coming from. So you know, take a look, you know, patient-centric extends for me to electronic health records. Go become a patient and see what the experience is like. Go find out when you walk in with a piece of paper, writing down, trying to remember all your medical history, giving it to somebody who then has to transcribe it into a system who doesn't put the right dates, doesn't put the right disease, and you have no way of correcting that. That's where we start from. Or computer systems that don't talk to other computer systems. Or people who are critically ill, like cancer patients, who need to go from place to place to place. And it just feels, I mean, they wring their hands because they have to carry their records from place to place because the systems don't communicate. So patient-centric means a lot of things to a lot of people. I think that we can do better, we need to do better, we need to pay attention, and I just don't, you know, I hope we're going to get there. I mean, there are a lot of things that we all have to pay attention to. You know, payment, we have to figure out how to make sure the payment incentives are in the right place. Centers for Medicare and Medicaid Services, CMS, has put a model in place called the Oncology Care Model. And the centers that participate, the practices that participate, along with not only CMS, but a number of other private payers who come together to do this, they pay a certain amount per month for, you know, patients who are on chemotherapy or on treatment, active treatment. And hopefully that money will be taken to try to improve the quality of care. Urgent care centers or off hours, let's phrase it a different way, off hours facilities. Can be a doctor's practice. It doesn't have to be an urgent care center. But off-hours facilities to try to take care of patients at nights, on weekends, maybe even to give treatment on nights and weekends when maybe somebody who's trying to work and hold their lives together have an option. What about a weekend? Did somebody have to go to an emergency department to get an IV fluids because maybe, unfortunately, they had a reaction to the medicine, you know, severe nausea and vomiting? Maybe we need to rethink this. There are docs out there and groups have gotten together and are thinking about this. I'm aware that ASCO has started a program to try to create a medical home to pay attention to these issues and to try to rethink how we give our care. We need to do more. I can tell you the American Cancer Society is very concerned to make sure that patients have access to high quality care and that their needs, whether they be immediate or palliative care. One of the interesting questions is, when does it start? When does all that begin? It begins the day you walk in the doctor's office and say, and somebody says, you have cancer. That's when it starts. And it starts in maybe a little bit different way then than when you walk in the door and say, I'm sorry to tell you your cancer has come back. They may be different conversations, but it's the theme that's important. And putting the patient in the center of experience, we could do a lot better.